Uh, Good evening, everyone. I know it's pretty late, but we are starting this webinar at 10 p.m. just to enable PGs to have a better experience, a better opportunity to attend to the webinars. Most of the webinars are conducted at ungodly hours for the PGs, 6:30 p.m. when your evening rounds are there. So we have aimed this career series where we give people an opportunity to pursue careers other than the traditional MCH or whatever the society expects out of surgeons these days. And the last series was about a career in hernia surgery. We had a very young surgeon, Dr. Hem, talking to us. And today we have two accomplished surgeons. One of them is going to talk, and the other person is going to moderate. The first person is Dr. Samrat Jankar. He's a colorectal surgeon running his own colorectal unit in Pune. And the next one, whom you all people, especially in Chennai, would know, he's Dr. Prem Kumar Balachandran, a specialist hernia surgeon, and who is the coordinator and the head of the Institute of Hernia and Abdominal Wall Reconstruction at Apollo Hospital. It's a newly started unit, and it is very heartening to see that such subspecialties are emerging in general surgery. It gives an opportunity for general surgeons to subspecialize and excel rather than spending time in pursuit of degrees. So we have two extremely accomplished surgeons here, and for those of you who are unable to catch this on our Zoom, we'll always have YouTube. And before that, I'll just like to introduce myself. I'm Vinayak, and I'm a surgeon here in Chennai, and I run search tests, as a couple of you know. So over to you, Dr. Samrat.
Yeah. Thank you, Vinayak. Should I start with sharing the slide?
Oh yes, sir. You can share your slide, sir.
Good evening, friends. I am really thankful to Vinayak to give me opportunity, and also I am really feel blessed to have such a good one of my friend Dr. B. Prem Kumar sir as a moderator, and he is a senior surgeon who will guide us during this colorectal career choosing option. We can get all thought of sir along with me so that we can know what we can do in this field. So friends, I am just talking on career option in colorectal surgery. Myself, Dr. Samrat Jankar. I am working in based at Pune Symbiosis University Hospital. So 10 days back, the Vinayak called me and told you need to talk on a career option in colorectal surgery. That time, I had surprised. I told him, man, I am not the person who is most accomplished in colorectal surgery, and n number of people are there in India at present doing very good work in the colorectal surgery. If you take any subspecialty in colorectal surgery, if you take cancer, if you take even complex fistula, pelvic floor problem, n number of people are there doing all these things. But what intention he just suggested me that at present this is talk guiding towards the people who has completed post MS, and they are in thought process that they want to get onco and GI or other specialty in MCH, and then they think that what else options are there. But you are the one person who has traveled the path of DNB GI surgery. You are GI surgeon, and then you want to develop your passion or you want to develop your subspecialization in colorectal surgery. Then you can tell them, is it a path you have to travel through GI surgery and go into the colorectal, or it can be possible to going into colorectal. So that's what I intended to talk. So I just taken up this challenge. We will go through what all the thing we can do it. So everyone, if you take myself or any MS guy, Vinayak or Prem Kumar sir, once we complete our MS general surgery, it's kind of big question. What next? Is it MCH or DNB super specialty? N number of super specialty are there. Friends, getting the super specialty also really tough job because need lot of people are preparing 1 year, 2 year, 3 years sitting and again preparing for same specialty, and few of the people are diehard of one branch and doing that again and again. And few of the intelligent surgeon, what they do, they start practicing, go to the 2 tier and 3 tier city, and they start practicing and learning from the short fellowship. But over the period of time, eventually they feel that they are less than the other. But this is also not true. But actually, what the time is telling, we need the focused learning about the particular subspecialty. If you take Prem Kumar sir, he has developed AWR work in Chennai really well. Like anyone capturing one subspecialty, working over the period of time, definitely it will crack. That's what I am going to talk about the colorectal surgery in next few slides. So if we are going through that phase of post MS, it's kind of very big competition. What to do next? It's a competition how to set up the practice or what to get the super specialty. Is it if you take a GI surgery or onco surgery, it's kind of full of competition. But actually truth is something else. If you complete super specialty, again the competition as compared to the demand which is needed in the society is more than the super specialists coming out. It's really disheartening, because the post MS guys are doing more number of things. If suppose one person is completing MS general surgery, doing good laparoscopic work, he has more opportunity, because even a smaller center, smaller hospital also can get him, and he can do n number of broad range of work. But when we leave our specialty of MS general surgery and we go for suppose plastic surgery, neuro something, and then we come after 3 years, we see that the demand in the demand in actual society is less than the MS general surgery. And in fact, if this trend goes on, the time will be there where super specialists will be more jobless. That may be scenario going to come. So what actually we are having a broad thought is, the person whom corporate will select, the person whom the job opportunity will be the person who is super specialist, most qualified, doing wide range of surgery, and actually the fees are less and giving more revenue. Actually thinking about going for job, we are hunting toward the super specialty. But actually if we are going for that broad specialty, it's, if we tell about the onco or GI, we are just broadening our the specialty from general super specialized general surgeon. It's going to be a big trap, because today we are going to enter, but tomorrow if subspecialty person is landing in the same setup, he will capture his subspecialty, and then it will be a really trouble for us if we choosing, if we considering next 10 year afterward work. So if we see today's whatever happening, it's kind of most of us follow is complete the general surgery, go for MCH or DNB, or you go for in MCH DNB. Most of the people are preferring for onco GI, and other people are also fascinated about the neuro, euro, those kind of thing we are doing. But actually what is needed in future is, need of the time is focused learning about the subspecialty. Particularly it can be a bariatric surgery, it can be HPB, it can be a colorectal surgery, proctology, hernia AWR, and breast surgery, in number of the subspecialty. But friends, if we go and see in the first tier city, at present it is happening, the person who is focused towards the subspecialty is cracking more option than the person who is doing the just general super specialist general surgeon is having lot of trouble. So we need to focus now, so that upcoming next decade will favor us to do more work. Otherwise it will be really tough. It's really very feel bad to tell this word that GI, surgical onco and surgical gastro are nothing but dying branch. And I think in Western world it is happening, and time will come where we also need to scrap this GI onco and GI surgical gastro and go for the subspecialty. It's going to happen in upcoming time. So if we take all subspecialty all doing well, but I wanted to talk about the colorectal surgery. If it comes to colorectal surgery, it's a broad range of practices there. We can think of benign colorectal pathology, it kind of diverticular disease, it kind of IBD, it's kinds of pelvic floor problem. malignant coloproctology, malignant colorectal pathology, malignancy of colorectal surgery, if done by good hands, in good understanding, or subspecialist who is doing more in that field, has a good result. I have seen during my training program, when the person doing more number of surgery of particular colorectal surgery, his recurrence and his problem of his radicality of the surgery is far better than on and off who is getting the chance. It means that if we have more better surgical skill or more and more number of exposure of the same case, you may be a better person to give a better result. Pelvic floor problem, frankly speaking, in India we have not even cracked the 5% of the pelvic floor problem. With increasing our westernization of lifestyle and change in the food style, definitely this is a big problem in Western world, and upcoming decade I feel this will be also big problem. At present it is a problem, we are not having specialists to deal, because of that we are not able to detect that it is a problem, but in upcoming year it will be one of the big trouble, and it will be the big chunk in the colorectal surgical group. IBD, Crohn's, it's 10 years before we are fairly very rarely going to see these patients, but Crohn's number is increasing like anything. In GEM, when I left that time, we used to get at least 2 to 3 Crohn's per month. That's good, very huge number, and those all are coming for the surgery, and this number is going to increase because our lifestyle and food style is changing. And none other than the proctology. Friends, proctology, we were thinking that it's a branch. No one was willing to tell that I am proctologist 10 years before. Now few proctology guys are doing very well, and they are growing rampantly, because this problem need a specialist who need to think what happening at the physiology, who should not do over or also not to do under, so that the disease will get cured. So in this colorectal surgery, all advancement will come, because laparoscopy, colonoscopy, laser and robotic surgery, everything applicable in colorectal surgery, which is the not case in other specialty, other subspecialty. And more than that, evidence has proven in this specialty the result of minimal invasive surgery or advanced technology has lot of scope doing better surgical skill. Why I am passionate about the colorectal surgery. I have been trained and I have been done my DNB GI surgery in one of the good centers, Gem Hospital. Despite of that, when I completed, my mentor told you have to choose one subspecialty, because next 10 year after it's a branch which will grow. It's not the GI surgery which will grow. So last near about 2 year, I am more focused about the colorectal surgery. I feel colorectal surgery has wide scope of services, and there is most balanced subspecialty. What we need a good chunk of cases which can give you revenue, and also big cases which can give you more satisfaction. And also we don't want more stress if we are going to do. I don't tell most of the people are doing transplant and HPV work, it's really good, but if same practice if we continue after 50 and 60, it will be more stressful. But if you do colorectal surgery, if you do proper, you understand the physiology and you properly, and most of us are doing at the general surgery level also, if we do a proper care, we have very good outcome, and our routine life will not going to hamper, because this surgery need maximum 3 to 4 hours. In fact, you do major surgery also, you can finish in 4 5 hours. And plenty of bread and butter. If you take a piles, fistula, fissure, and pelvic floor problems, even colorectal cancer, there are plenty of bread and butter cases where your energy investing is less, but fruitful outcomes are more. And numbers of colorectal problems are increasing disproportionately because of westernization. Colorectal cancer is the second biggest killer, and at present India is fifth in number of colorectal cancer, but it is increasing like anything. We are not having documentation in India, but if we see upcoming 10 year, definitely all colorectal problems are going to increase in more number, because it is related to lifestyle. And frankly speaking, IBD and pelvic floor in India, we have not touched more than 10%. It is the most untouched area. If we talk before 5 5 year, hernia is one of the untouched territory. Now the AWR surgeons has explored every corner of hernia, but same thing in 10 year, I think there is a wide scope to explore in pelvic floor problem and also IBD to gain more knowledge and give better care. And the most important is, even if you choose the subspecialization like HPB, upper GI, transplant, if you go for colorectal surgery, you are not always institutional dependent, except few cases where you need exentration or where you are doing surgery on the recurrent cancers where we need institutional practice. But most of the practice can be done even at the 2 tier city, even at the 3 tier city where you have good amount, good infrastructure. That's enough, we can go ahead with this surgery. So we are not institutional dependent. And most important, friends, your knife will give more satisfaction for the patient. If you get any fissure, chronic fissure, if he is need of the surgery, you do surgery, that person will not forget, because his pain cannot be relieved by anyone. And if your knife relieves his pain, he can't express, but he will be loyal for whole life to you. And most important is, colorectal problem or the problem, these are most of the cases are directly referred cases, rather than the referral by anyone. And these are beyond the scope of scopy, sorry to tell, because now medical gastroscopy is going in our GI in every corner. If you take upper GI and HPB, scopy is reaching in a very big scope. But in colorectal, except scopy to do polypectomy and stenting, scopy can't reach in every corner. We have big scope even after 10 years if we have more number of increase in opportunity. And I am really thankful for my mentor, Dr. C. Palanuli, because he is the one person keen to address me in 2018 when I finished my DNB GI surgery, that if you want to label yourself, don't label as a GI surgeon, label as something out of the 5 and choose out of the 5 so that you will be one after 10 years. People will recognize. If you tell everyone that I am a GI surgeon, it's very difficult after 10 years someone will recognize you. So that word struck me. And 2018 when I completed my GI surgery, he wanted us out of 5 to stay, and he told choose one subspecialty. That time I just blindly chosen that I want to go for the colorectal surgery, and 2 year I worked completely in colorectal surgery in GEM Chennai. Second person is the Dr. Raj Pandan. In his unit of colorectal surgery in GEM 3 year, I spent around 13 to 14 months. But why I got interest is because HPV cases somehow used to have, this is known in having some leak or complication, but colorectal cases used to come like hernia and hydrocele or coli. They used to go home third and fourth day, which inspired me. It's kind of eras. Next day he used to push the patient to take a liquids and soft diet. If there was no stomach, patient used to go happily to home. And most important is, after 1 or 2 year also, while completing my course, I used to see these patients are coming happily. So that was not same scenario with other subspecialty which are running in the GEM hospital under Palanvelu sir. So next, the person who entered my life, who has given really good guidance, is Dr. TK Rajesh. He is the person who has worked in Plymouth and he's a consultant there. He came to GEM hospital when GEM Chennai started, and his surgical thought process about the colorectal surgery: divide any surgery into 10, and every 10 step has to be monitored with the time, and every 20 minutes he used to tell that you are not still ready to do colorectal surgery. 1 year he was telling every step, and if we cross more than the time what he has devoted, then he will tell you are still not ready. That used to give us, me and Dr. Pinako was under him, that used to give us, no, we are learning, we have to learn. But after completing from GEM Chennai, when I come and started my work, I felt that all the steps were running in my mind, and every step he has taught us so meticulously that when case comes, that thought process will go on. And he is one of the good mentor, and we need more mentor like him in our India. So other two men who entered in 2019 in my life are these two people. I am really grateful to see them. That question of taking colorectal surgery as a passion, it was confirmed after seeing these people. I went to learn fistula from Dr. Arun Rajna Sukal and Dr. Parvesh Sheikh. These these people left whole colorectal surgery and they are doing only fistula surgery. And in fact, Dr. Parvesh Sheikh, when I visited his center, he used to refuse simple fistula and 1 month waiting period. He used to tell that I don't want to do fistula surgery. And only one thing what Rajana Sakal sir told is the colorectal has a wide scope of patient. After 5 years, if you develop in one area, just concentrate on that. It has n number of cases who will come you because these people at present only few people are giving good service for them. If you give good service, you are bound to crack. Just continue on this part. So I am really thankful for these two people, and I feel everyone should visit these two peoples also. And if we just go through my life journey after MS, which I want to stress on is I just completed my MS general surgery from Solapur in 2012. After that, I had an opportunity twice because I had 80 rank in MCH in Maharashtra, and also DNB first time I had good rank. But in spite of that, I preferred for the family life. I married, and after that I had first kid, and after that I thought I have to go. This was a story when 2010 my professor in general surgery used to read art of laparoscopy, and then he used to do his surgical cases. That time he used to tell that the one person sitting at the Coimbatore, he is a kind of writing all the thing, and this is a kind of Bible, and from that if we just crack, you will do the good laparoscopy. That time I thought, why not to go to the person who has written this Bible? For that reason I just given DNBJS surgery, and it was the kind of visa for me to enter into the gem. And with that I entered to learn the laparoscopy from Dr. Palaniolu sir. And 15 to 18 I completed DNB surgical gastro, and from 18 to 20 I just worked in Chennai as a consultant colorectal surgeon, and I had two kids, second kids as a daughter, and 220 onwards I am working in the Symbiosis Hospital Pune. Why I am just stressing is it's not our only the career. Along with that, we have to think about the family, we have to think about the health. For me, it's profession is most important, we have to accomplish, but over the time period it will get, if you are devoted for the profession, it will come in a good way. But same time we should not neglect our family, and most important is our health. If three things come together, definitely today or tomorrow we'll be successful. So we have to think on that. And here I complete my short talk. Thank you, Vinayak. If any
Thank you so
question
much,
is there,
sir.
we'll go.
Premkwa sir, you have any questions to ask Dr. Samrat?
Uh, More than questions, I've got some, what can I say, some opinions. At the outset, Samrat, you said, are you the right person for giving this talk? And should Vinayak have, selected a more accomplished or senior person? I think you've done a fabulous job. And I think you are the right person because if you take an accomplished or a settled person, their age difference will be different. And their time of practice would have been completely more different. What the youngsters need today is a person who's just completed and just started his practice and who's doing well right now. So I think you would be the ideal person to actually, share your feelings with the youngsters. And I think
Thank you, sir.
and I think your presentation was on touch. It was fantastic. And moreover, you touched on, the important aspects of holding family and health very, very important. Because when Vinayak spoke to me about this, the need for this talk was, he was telling me that a lot of youngsters are sitting in practice, studying, and they're getting tense and worried about what to
Yeah.
do about the future. So I don't think you need to be tense. Okay, that's the number one thing. And like you said, always maintain your health and be focused. Another important thing is, like your last thank you slide, I am also grateful to the same people like you are grateful to, because in the year 2002, when I came back from Dundee, I also worked with Palani sir in Gem Hospital when Raja Pandyan was my colleague. And Rajesh actually is my senior in MBBS. So we all know each other very well. So it's a nice coincidence. Just to go through a short journey of mine. Is it okay, Vinayak, or you want to take questions
Absolutely,
at the
sir.
same time?
Yeah,
Absolutely, sir.
definitely, sir.
Absolutely, because you are also a person who is concentrating on one subspecialty.
Yeah.
And
See,
doing
so
very well job.
Yes,
fantastic.
absolutely.
See, so basically, how it started was like, as Samrat was saying, is once you finish your MS, everybody is, now what, now what? So similarly, when we finished MS, this was way back in the year 2000. It was a trend to get into MCH immediately. So at that time, I tried for my MCH exam like most of you are trying, but unfortunately, I didn't get it. And at that time, there was not much internet access like we have nowadays. You have to, through somebody who tells you or something. So one of my friends from the UK told me that there is this MMAS degree, that is Master of Minimal Access Surgery in Nine Wells Hospital, Dundee, under Sir Alfred Kusheri. So I went into the internet and I got the address and I applied. I sent it by mail, by courier. So I was waiting. In the meantime, I was working with Professor Surendran in Stanley Medical College as a senior registrar. Then surprisingly, after 6 months, I get a letter from Dundee saying that I've been accepted. But unfortunately, I had only 2 more months to apply, so it was not possible. So I applied the subsequent year. So I went, finished my MMAS under Professor Kusheri, and he was a person who used to teach us the most important thing is like even me and Vinayak discuss about ergonomics of surgery and how to start a laparoscopic training program. All these basics were inculcated to me by Sir Alfred Kusheri. So when I came back to India, I joined with the Palnivelu sir in Gem Hospital, and that's where my more focus went, and the practical hands-on training came with the Palnivelu sir. Then after that, I joined Ramachandra Medical College as an assistant professor. The thing is, once we started doing these laparoscopic surgeries, I was, what can you say, a glorified general surgeon. I used to take pride in doing every surgery. I used to take pride in saying that I can do a corn foot up to ripples. Okay, and to my credit, when the robotics first came to India, it was first in Apollo Hospital, Chennai. So if you actually search for robotic coledocal cyst excision on YouTube and you search for my video goes way more than 8 years back. So actually, I've done the first robotic coledocal cyst in the country. I've also done the first robotic axillary dissection, which has got no correlation at all. Okay. Then I used to do colorectal, I used to do hepatobiliary, laparoscopic hepaticojejunostomies, laparoscopic total gastrectomy, thoracolaparoscopic esophagectomy, and I used to take pride in saying that I'm a laparoscopic surgeon who can do everything. Then I realized years down the line, I'm not going anywhere. I'm operating, yes, I'm becoming a good surgeon, but at the same time, some of my colleagues, like I can give you examples, Dr. Rajkumar Palniappan, he focused only into bariatric. Dr. Venki Munikrishnan focused only on colorectal. I'm sure everybody knows Venki.
Yeah.
And I saw the way they were, zooming in front. And in between, I used to go for short focus trips. I went to, I went to Belgium with Professor Kadir for bariatric training. I went to Hong Kong with Professor Tang for robotic hepatobiliary. And I came back. But unfortunately, I couldn't shine. I was doing everything, but I was not making a point. Okay, I was not actually, trying to get somewhere. That's when even my friend Raj called me and said, "Prem, you're a fantastic surgeon. You got to start concentrating on something. You got to focus on one thing." And that's when I started concentrating. I thought, which surgery do I like best? And obviously, yes, hernia was my favorite. I love to do even today. I do everything, but now that's when I started concentrating on AWR and hernia. And thanks to Dr. Ramana, I must say, he has changed the face of AWR not only in India but I think all over the world. So he has made the AWR community all over the world. It's just like in our hands. We can communicate with anybody through the social media societies that have been going on to Ramana sir. And I just happened to send a message to Dr. Igor Belyansky on Facebook saying that, "Sir, I want to come to you." And he said, "Okay." So life has become so simple. So I contacted his secretary and I went to US. I trained with Dr. Igor for a couple of weeks and I came back and I started my unit. And now, as all of you see, I'm a name to know in the field of AWR of the country today. So what I'm trying to tell you youngsters is, if you notice even today, most of the top guns, if you name them in the country, like in bariatric, you take Narvaria sir. He is not an MCH, he's MS. You take most of the top surgeons in the country, half of them won't have super specialties. So don't focus on, I have to finish MCH, I have to finish this. Try to go for, there are a lot of opportunities in the world. Okay, it's not that, you have to go and sit for your NEET exam, this, that, and get very, very focused on your exams. There's so much opportunities in the world. In fact, recently, one of my junior colleagues, Dr. Prem Vignesh, he finished his MS in Ramachandra. He was working with me in OMR for some time. He applied in Germany. He went there. He impressed his professor over there. Now he's settled down in Germany. So like this, all of you can actually, search the web. There's so many opportunities where, you can apply all over the world, like in whichever specialty you want. Focus on a specialty and try to do only that. And in that way, you will shine very soon. So, that's my point for the day.
Thank you so much, sir. Thank you so much, sir. I think two very inspirational points from Dr. Samrat sir and Dr. Prem Kumar sir. I have a few questions for Dr. Samrat sir. What are the opportunities? Where are fellowships available in colorectal surgery? You have spoken about the scope of colorectal surgery, and I'm hoping that everyone is pretty impressed. But where do they go and train? How do they apply?
At present, if we talk about going outside, out of India, if we have anything in the UK and US, lot of fellowship in colorectal surgery is going on. But if we take in India, few of the center, for my knowledge, Jipmer and Shere Kashmir, they are running a completely program, colorectal fellowship and MCH program they are running. And other than that, if we are focused towards the cancer, the Tata is giving a colorectal cancer fellowship, which is completely available. And recently, last 1 or 2 years, the colorectal fellowship has been started by MUHS near about 4 or 5 centers in Maharashtra. Also, they are training, including Rai Patankar sir's Gen Hospital is giving colorectal fellowship of 1 year for post MS. So, and GEM is also having colorectal fellowship programs.
Okay. There is, for the interest of viewers, there is also one more good colorectal fellowship program at CMC Vellore. A very good mentor and a friend of mine, Dr. Rohit Mittal, is conducting a good colorectal fellowship at CMC Vellore, where trainees actually get to perform laparoscopic anterior resections by the time they finish. And all the trainees who are finished over there are being placed in very good places in India and abroad. What would be the difference in training between spending time in India or spending time in UK or US? Is there any difference, or would you say that it's pretty much the same?
I don't feel, because whatever trainee, if we see in CMC value, Rohit Mittal sir is doing really fantastic job. Shere Kashmir also, they are doing really good colorectal surgery. It's a number. If we are having good number and specialty based practice, definitely we'll have same quality here. If possible, going outside and getting good exposure is good. If not, here is also is good option. It may
Okay.
not be a big difference, I feel.
Vinayak, Dr. Venki Muni is also running a course in Apollo
Yeah.
Brain.
Yes, sir. Yes, sir. Dr. Venki Munishan is running a robotic colorectal.
Robotic colorectal, yeah.
And is it, there are a lot of people, I mean, my students of search test, and a lot of young people who talk to established GI or oncosurgeons, and a lot of people say that if you practice colorectal surgery in a very competitive place, you cannot make a living. Is it true? And did anyone try to discourage you when you said that you want to be a focused colorectal surgeon?
It's not, but only thing is, what concept is coming is, when we are in general surgery, when we are doing residency, that time we feel that we are doing all colorectal surgery, and it's general surgery is colorectal surgery is nothing but general surgery. That's kind of thought process will come, and because of that, we don't feel it as a subspecialty. We feel that it is a general surgery part only, but actually if we start doing only focus work, then only we can give a good result. And there is, I don't feel any discouragement. And in fact, if we take Venki Munnikrishnan sir, what he has done, his whole journey, initially he has also had a lot of struggle. If you bound to go ahead with one subspecialty, initially struggle will be there in everything, but over the period of time, definitely if you are doing one work, you will crack on the better side.
So this question I would like to direct to Prem Kumar sir. You
Yeah.
are getting extremely successful right now, sir. People are recognizing you all over the country and perhaps all over the world in many international forums as a focused AWR surgeon. And at any point of time, did you ever feel that I should have done an MCH, or does an MCH offer any value?
See, with age, you wisen, okay? So I definitely say I have a regret that post MS, yes, for 3 or 4 years, I had this degree fascination. Like I'm sure all the youngsters here today. That time it has to be MS, MCH, FRCS. Okay, but as time goes by, then your priorities change. See, because today, just because you're an MCH, you're not going to get 100 patients per month. That's not going to happen.
Absolutely, absolutely.
Okay, it also depends on your priorities. See, a lot of people if you want to go on the teaching line, you want to join an institution, then maybe an MCH is really great. But if you want to become a good corporate doctor, you want to do good hands-on work, you want to be recognized, then I think, probably the earlier you finish and the more earlier you start focusing on your subspecialty, that matters. So as time goes by, I think the qualification also will come with time. To tell you the truth, I got my FRCS only 1 year back. Okay, and I'm almost 50 now. So degrees is not a big deal at all.
You don't
It will
look
come
50,
with time.
no?
Thanks for that. But I mean, whatever said and done, it comes with time. It will come with time and experience. Everything will come to you. So don't focus too much on qualifications. Focus on what you want to do and focus on how to get there at the earliest. That is smart thinking.
Okay.
And MS qualification is more than enough. Then we have to jump for something else.
Yes, 100% I agree with that. Yeah.
You both are doing extremely specialized work, and Prem Kumar sir, you might see a proper AWR case, a recurrent, multiple times recurrent hernia, operated by a very senior general surgeon who is not specializing in AWR, doing a simple onlay meshplasty, or Dr. Samrat, so you might actually see a straightforward C rectum in which the principles of total mesophilic excision have not been followed. How do you deal with these cases? And there are people who advertise better, like they call themselves as cancer experts, surgical oncologists. They do everything. And how do you deal when these patients come with a recurrence to you? Do you tell the patient that they have been operated suboptimally, or do you try to protect your colleagues? How do you deal with such tricky situations? Especially if the patient asks you, sir, what was wrong in the previous surgery?
No, I'll tell you one thing first. Never ever talk down on any other surgeon, because someday the same thing may happen to you also. We as a fraternity have to stick together. Okay, I always tell the patient, if he tries to blame the previous surgeon, I will say it probably may have gone wrong, but he had no wrong intentions. We don't try to downplay another surgeon or try to criticize another person, because tomorrow you don't know who's going to say the same thing about you. So that's one very strong point we need to take. And yes, like you say, a lot of times the patient comes to us, and particularly today with the medico-legal concepts going on, a lot of patients even tell me, this surgeon has done something wrong, I want to sue him. Many times it has happened, and I've not pacified those patients. I've said, no, what he has done is right in this setting. He has done his best. But things happen. If I had done the operation, probably the same thing would have happened to him also. So you never know. There's something beyond us. And everybody reacts in a different way. So, I mean, even in the best of hands, complications can happen.
Yeah. Absolutely, sir.
And same context, Dr. Palaniulu sir used to, as I was in GEM, we used to get a lot of referral cases having some issues. That time we used to tell next day morning rounds that, sir, this patient has came and surgeon has done this. That time he used to tell that what he has done is no one you are supposed to assess. Your job is how to make it as a good, because the technical expertise of him and the scenario, what he has done, what was the exact scenario. If suppose you are doing lab coli, suddenly you have some issue related to ergonomic or something else, technical issue is there, it will also land in trouble, because we are not knowing exactly what was the environment at that time. You are no one to decide on that part. But if you want to get information, you can call the surgeon and get the information, and you want to suggest to the surgeon, call him and tell. But don't judge by his problem that he has done wrong, and never ever comment on that problem that this person has done wrong, it could have been done better. Because definitely what sir told, today he is there, and same time we may also going to land in trouble. So our surgical fraternity, we should not tell any bad mouthing or backstabbing. We should avoid on that problem.
At the same time, Vinayak, you mentioned another point about advertising and being a socially, prominent surgeon. I think, unfortunately, in today's world, the social scenario is changing. If you don't blow your own trumpets, nobody else is going to blow your trumpet for you.
Absolutely.
Okay, make a noise, make your presence felt. I think Dr. Ramana has given many talks on the importance of social media in your practice. Okay, it has become a very, very social media directed life today. So I think whenever you get an opportunity to portray yourself, please portray. Don't feel humble. A surgeon should never be humble. You should not have ego, but don't be humble. Whenever you get a chance to boast, please boast.
Absolutely.
It will just,
Nobody is going to blow your trumpet as you. I think that's
yeah,
a very true word spoken.
it will get you the necessary publicity and it will also get you your patients also.
That's
In today's practice, it is very important.
True, sir. True, true. Dr. Samrat, you had mentioned in your slide that corporate hospitals, I mean, this is going to be a little uncomfortable question. Uh, you had mentioned in your slide that corporate hospitals prefer a surgeon who does a wide range of surgeries at a lower rate of cost. So, does you being a colorectal surgeon put you at a disadvantage with securing a job in a corporate sector?
actually, this is for the entry I am speaking. It is
Hmm.
not after that. After that, if some person is doing a specialized work in subspecialty work and which is cracking a number of patients, definitely he will be more advantaged and long term associated with that association. But when a surgeon, when he completes and he want to enter into the any corporate, at that time the corporate also will think that we need to have a person who is having more qualifications, so that on the qualification we can judge him that he might be a good surgeon, and also he should do a wide range of surgery. That's what the GI Onco, we are thinking that we can do wide range of surgery, we can be the best product for the corporate. But once we enter into that world, that time it will become very difficult if the subspecialization done person is coming into that same area and he capture one by one subspecialty people are capturing. That time it will become difficult. Rather than thinking that trap, we should think for our passion and we should go ahead with passion, so that it will crack more better than what we are thinking about others and thinking to do the super specialty.
Your
See,
thoughts on this, sir?
that's a very good point. See, because like I was telling you, when I was in main Apollo, I was like priding myself in being able to do every case. I was wondering why cases were not coming to me. But just think about if you were to take your relative to a hospital with a bariatric issue or a colorectal issue, will you go to a general surgeon or will you go to a guy who does only colorectal?
Absolutely.
Obviously, see, because I mean, I once upon a time I used to do a lot of bariatrics also, but now I'm a little out of touch. So about a week ago, I had a bariatric case, and just since I've been out of touch, I called one of my colleagues from main Apollo. He's very junior to me, but he came, and the way his thought process and the way he was operating in that case, it just shows, because he's doing only that surgery every day, so automatically you become better. So that way, if you want me to tell you, my first AWR, I think somebody is also in the group. I think he will realize, he will also know. I took more than,
Dr.
yeah.
Sabri, sir, you can join, you can switch on your video.
Yeah.
Is he there? He was here for a while, I guess.
Yeah, I remember seeing him. I think he's gone away. Anyway,
Yeah.
so my first ETEP with the divarication Department took me more than 8 hours. Okay, but as time goes by, now it takes about 3 to 4 hours. I mean, you were also there for a last case. I remember. I did
Oh,
one.
yes, sir. Yes, sir.
We did one case together. So time as time goes by, you definitely become better. So that's
Definitely,
why I'm saying.
definitely. I mean, after
For,
that, your case, we went for a term, and it took quite a bit of time. It took
it's
quite a bit of
okay.
time. But the
Yeah,
fact that we completed it independently is a big achievement. And Dr. Prem Kumar, sir, you are being called by a few surgeons
yeah,
to assist
yeah.
and to teach them ETAP, complex AWR cases, or senior surgeons who do a lot of open AWR, who want to get into lap AWR or minimal access AWR. And Dr. Samrat, so you might also be called in the city for to assist senior people with their cases. How do you deal with their egos? Um,
That's a tricky question. But honestly, so far, touch wood and thank God that all the seniors who I worked with are quite adjusting people. And obviously, if a senior person can lower his ego to call a junior to come and assist him, there itself there's a understanding going on. Okay, if a
Absolutely.
guy has got so much ego, he's not going to call a younger person to come and help him because he's interested
Absolutely.
in, because he's interested in learning the newer concept. And if you want to learn, you have to come down. See, even today, if you are willing to teach me something, I'm willing to come and learn from you.
Oh,
That's
Okay, no, because we are
you're flattering me.
all of us are in the learning process, and we never
yeah,
stop learning till we die. And probably, see, the way you guys are so good in social media and electronics and gimmicks, I can learn a lot from you guys. Everybody can learn from everybody every day.
yeah. That's true. That's true.
And in the same city, you're working in Pune, you're working in Chennai, big cities. you're doing quality work. I'm just thinking out loud whether it is possible to improve the referral systems where surgeons can increase intra-surgeon referrals to make sure that the patient is benefited maximally. Because, sir, even though you are an AWR surgeon, majority of the AWR cases in the city, just by sheer numbers, would be done by person who is not qualified.
See,
And
yeah, go
your
ahead, go ahead, please.
colorectal is pretty much the same. How do you improve the referral systems? Is it through social media, or is it through some other strategy so that the patient is benefited in the in the maximum? Because we don't have an institutional based practice like NHS where all the cases get referred to one place. So how do you manage to sustain your AWR or colorectal practice, or how do you manage to even concentrate on it? Because numbers are always an issue in a big city.
Numbers are definitely an issue. So that's why I still do every surgery, but I'm concentrating only on AWR. I've not just stopped doing everything else, okay, until I reach the stage where I get sufficient numbers. But you got a very valid point there, because unlike certain other, like if you say Delhi or Mumbai or something like that, the South, unfortunately, and I don't know about Pune, but in the South, uh, intra-doctor referrals is going to take a long time to go, because every surgeon wants his piece of cake. Okay, just because he's not good enough, anything is going to give it to you, I don't think so. Let's be brutally honest here.
Absolutely.
Yeah, if in a periphery a guy's got a big ventral, who would actually benefit by a good ETEP, he's going to do an open onlay mesh only. He'll do open, probably he'll mix it with abdominoplasty, he'll put it on onlay mesh and he's going to repair it. He's not going to send it to you. So I mean that's something which you all need to focus on. Uh, Probable ways could be, yes, different social media, and probably if your hospital has got a good marketing team, they could help you out with that. But being in a big corporate sector like Apollo, we've tried all these strategies, but it really doesn't work.
Absolutely, sir. It's absolutely.
Yeah.
I have been here at Pune. Same system is there, and I think for doing our subspecialty same time, we have to project for that. We are the doing only subspecialty related to whatever we have pursued. I am just projecting myself more towards the colorectal surgery, and other thing has not worked. But definitely in complex fistula, things are working. In fact, three time operated cases people started referring. I think in colorectal this is getting blessed, but over the period of time we focus on that, things definitely will improve.
I'm going to ask you a question. Again, this might be an uncomfortable question because it's related to economics, money. Uh, so, majority of the work in this part of this world is being done in government hospitals.
Yeah.
And most of our residents are in government hospitals, especially the very ambitious ones who are planning to get into the top specialties, who are actually extremely motivated guys. So, and the numbers in government hospitals are again pretty huge. You all worked in public health hospital settings at various points of your life. Uh, as surgeons practicing in corporate, would you be willing to partner with government institutions and teach residents on a regular basis? That's not going to
100%
bring
yes.
you monetary benefit at all.
100% I'm willing.
Definitely we have to do that work of training others, because if we want to develop our subspecialty, we want more people to pursue the subspecialty. Until and unless, if we take AWR, last near about 5 years extremely in South, Prem Kumar sir, Ramanna sir, and in Mumbai, people are doing AWR, teaching people and making more understanding about the subspecialty. And if more number of people are coming with same subspecialty, definitely all people, if one person is doing good work in the city regarding subspecialty, people will send the patient to that subspecialty person who is actually doing well. And I think to increase this work in the subspecialty, we have to train people. And when it comes part of the things from our earning from doing work at the corporate, same time I am definitely willing to work on training, that I don't expect anything should come from that.
I think this is something we should explore, sir. Premkumar sir and Samrat sir, I'm just going to get back to you over the next few weeks because
Yeah.
I definitely feel that residents in government hospitals need to be exposed to quality cutting edge work. The
Yeah.
process there are absolutely brilliant. They work hard, but there's always a shortage of time to do complex work. And everyone, the assistant professors, they're also pretty young, and they also need senior people like you guys to guide them and mold them into the area of subspecialization. And I think 10 years down the line, I think BJ Medical College in Pune and Madras Medical College can have general surgery, colorectal, proctology, or AWR specialized units. I think that's a very much a possibility, and that is something which is going to bring glamour to the field. Because ultimately,
Yeah, and that's the way to go. That's the way to go.
I think the entire where Dr. Venkatesh Munikrishnan or Dr. Ramana or Dr. Prem Kumar sir have played a major role is that they have glamorized the field. They have made it seem a very attractive option. No, I'm very serious, sir. Ultimately, peer-to-peer recognition is something which every surgeon seeks a lot. More than patient recognition or even more than money.
Yeah,
That's the highest sort of honor a surgeon can get is a peer-to-peer recognition and peer-to-peer honor.
100%.
So, and that can occur only if the field is glamorized, if the field looks attractive. Optics are extremely important in any
True.
specialty, and
Like
I
how Rangabhashan sir brought up the MCH. He was a
absolutely,
phenomenal personality. Yeah.
Yeah.
absolutely
Yeah.
every person who was, they were all force of nature. I mean,
True,
they
true.
were a force of nature by themselves. So I think that is a very important issue which should be addressed. Colorectal surgery, unlike other parts of the world, in fact, Pakistan and Bangladesh have very active colorectal surgery programs, which India has actually failed to have.
Oh my, okay.
Turkey has very good hernia programs. There's a specialized hernia hospital
Mm,
in Turkey. They have AWR programs in Turkey. They have specialized colorectal units in Turkey, and these are all developing countries. India should have caught up with them.
true,
But
true.
unlike fields such as surgical oncology or broad surgical gastroenterology or pediatric surgery or plastic surgery, subspecialties never had such glamorous people. I think till the advent of Dr. Ramesh Punjani, Dr. Ramana, who played a major role in making this field a very attractive field, there were not many people interested in hernia. It was, oh, it is just hernia. Nowadays, it is just AWR. It's not hernia.
Yes. Now it's
So
a big thing. True,
it's a
true.
big thing. It's a definitely a big thing. It is something as big as transplants. Right
No,
now, I've
I'll tell
seen
I'll tell all the youngsters down there. I mean, I've done a lot of surgeries in my life, but even till today, a complex TAR with an E-TEP is one of the most tiring and difficult operations to do. So it's not a joke, and definitely it demands skill and expertise. So don't think it's just a hernia. Like you said, hernia has become a very glamorous and a difficult field too. Yeah.
it is the same thing. The colorectal revolution is
True.
yet to happen, and
Yes.
I'm very sure that Dr. Samrat Jankar is going to be at the front of it, leading it. In 10 years, he is going to be the Venkatesh Munikrishnan of Maharashtra. I think the entire field needs more recognition, more publicity. And I want to tell everyone here, all the youngsters, about 25 of them are watching this program. A lot more of them are going to watch it on YouTube in the next few weeks. That choose your subspecialty wisely. This, your late 20s and early 30s, is an age when you should be spending time on skill development. It is not the age when you should be chasing degrees or sitting at home and studying books.
100%.
Yeah.
I mean, we're not discouraging you from an MCH. If you're in a field like pediatric surgery, urology, you definitely need an MCH because there are no good fellowship programs per se. But if you're interested in something very subspecialized such as transplant, colorectal surgery, you should be spending most of your time acquiring skills, learning with the right amount of people. Because after a certain age passes, your family commitments do catch up. And at that point of time, you will not be able to travel all over the world. You will not be able to spend a lot of time in skill acquisition. And I think that is the take home message where we want young surgeons to spend a lot of time being focused rather than focusing on degrees. Focus on your subspecialty, focus on what you want as a career. Any final word, Dr. Samrat and Dr. Prem Kumar?
I'd like to commend. I'd like to commend Dr. Samrat on a fantastic talk,
Thank you, sir.
and I'd
Thank you,
also
sir.
like to. I'd also like to, wish all the youngsters here all the best in your future. Don't get too stressed out. You live only once. Enjoy and be happy. That's it.
Oh, yeah. Thank you so much. Dr. Prem Kumar sir is also a very popular motivational speaker. Uh,
Okay. Okay,
so
guys. Follow me on Instagram, Dr. Premis.
I'm a secret fan of his Facebook page, which says everyone is a winner. So says Prem.
Thank you.
So,
Thank you.
and I do watch all of his Instagram short videos, and these are all very, I mean, just 30-second clips, which are extremely inspirational, and knowing Dr. Prem Kumar sir and Dr. Samrat sir on a little more personal basis, I must say that they are extremely successful, not just in their careers, but they're also extremely good family men. Uh, the videos of Dr. Prem Kumar sir exercising with his sons is a big inspiration to me, or a lot of young surgeons with young kids. So the art of balancing successful careers with family is something which all of us should learn from these people, because most surgeons these days, success often equates with broken families in
Yeah,
many homes,
that's right.
I
and
think
that is the trend which these surgeons are changing. I mean, what is your take on this? I think you would
I
agree.
think we should. I definitely agree with that. I think we should have the final words from our star speaker today, Dr. Samrat.
Thank you, sir.
Yeah,
Sir,
yeah.
you are there to tell. We have started. We
No,
are
no, no,
blessed
no.
to have you along with us to guide us. So I feel we should not be stressed for super specialty. In fact, there are two ways which I traveled. I feel I have gone through DNB super specialty. In fact, I went to DNB super specialty because I wanted to be with Dr. Palanivellu, sir. There is a big thought. We have to spend our part of life in leaders or shadow of leaders, so that we'll get that energy to do something good. That person's inception I went, and the good thing happened to me is I was more time with the colorectal department, so I was just spending more and more time in colorectal surgery. So we should not hunt for super specialty. Most, if we are getting, it's good. If you are not getting, just try to spend more time in a subspecialty which you are passionate, and also you think where you are going to practice in future. If you are practicing at what place and what kind of infrastructure is there, and what you can be a substitute in that area, according to that choose your subspecialty. And definitely it's a passion, and never compromise that. All thing will come, even today or tomorrow, in 50 also you will crack in one field and you will become a star. But same time, health and family will not give option to again crack. So don't miss that opportunity for cracking the other thing along with health and family, and choose your subspecialty and crack in that. Definitely it will be a good for you as a good future.
Sir, we have a few doubts on the chat. We have a very encouraging comment from Dr. Vineet Nakara. He's just said that a surgeon wants a private or academic practice, and colorectal surgery bodes well for both private in terms of finances and academic grants. And he congratulates you. He says it's an excellent
Thank
talk. Thank you, Dr. Samrat.
thank you.
We have one more question. Sir, can we choose FNB minimal access surgery in GEM and get into colorectal?
Yeah, definitely. In fact, last 10 days before, one of the guy from Kolkata called me and told me he's having good rank in FNB. He told, I am having two options. Yes, should I get the FNB or I should wait, because I am desperate for GI surgery. Near about 20 minutes, I spoken to him. This is not the important thing that we get only GI, and after GI again we have to hunt for laparoscopy and other thing. If you are getting the FNB in GEM, you will get exposed to three rotation in three units: upper GI, HPB, and colorectal. And after that, if you are interested in one particular subspecialty, you can spend more time in that subspecialty. If you spend that, your laparoscopy will also develop, and along with that you have opportunity to know that which specialty you like more. And in fact, most of the FNB guys who have come up, out from the GEM, they have chosen, most of them, either bariatric or colorectal to pursue as their career.
Sir, we have a question from Dr. Sudarshan. He's saying MCH versus MS plus subspecialty. Are there any insurance related issues where the insurance company asks that you should be a surgical gastroenterologist or surgical oncologist? Have you faced any such issue?
Not really, not really. It doesn't matter if you're post MS. I think any surgery should be all right. See, to tell you the truth, today in corporate sector, most of the physicians admit the surgical cases under them, and then we go and operate because they need to show their numbers. So I don't think it's really a big deal. It's not a big deal at all.
Okay. Sir, Dr. Ramakrishna Reddy wants your Facebook page name. Just type it out so that you can just repeat it.
It's everyone is a winner, so says Prem. I think I already sent him a private message, so it's not a problem. But you can put it for the thing of everybody, no problem.
Yes, I will just type it out. Everyone is a
Winner, full stop, so says Prem.
Okay. Um, okay. I think our doubts is also cleared, and I think we had a very productive session just before Diwali. I wish everyone a very, very happy and a very safe Diwali. Use these holidays to get some clarity of mind, clarity of thought about what you want to do in your life. We're not discouraging you from an MCH. We're just telling that focus on whatever specialty you want to be. Nobody is saying that you should do a fellowship in neurosurgery. MCH neurosurgery is the way to be. But if you are wanting to focus in hernia surgery or sub-specialties such as colorectal surgery, try to do it as fast as you can. The MCH route is not the only route. Thank you so much, sir. Thank you so much for being with us today.
Thank you, everyone, and happy Diwali to everybody. Thank you.
Thank you.
Good night,
Thank
folks.
you.
Take care. Bye bye.
Thank you, Vinayak. Thank you, Prem Kumar sir. Happy Diwali to
Bye bye
everyone.
bye.
Thanks a lot.